PLK Max Hospital from New Delhi, India. And it's very tough to get his time available to bring to Nigeria. And with great difficulty, we have the honor to bring doctor to Lagos. And I would like to invite Dr. Dharma. Choudhary, please, sir, we welcome you to this event.
Thank you for the kind introduction. Thanks all the community doctors who join us for this evening to listen us about marrow transplant, what we do. Thanks, Professor, for arranging everything. So I can tell you about, I am a graduate from our this Organised Medical Science out of India, and then I did my transplant fellowship for 1 year, and then I moved back. At that time in 2007, nobody was doing that transplant, and my mentor pushed me back to India. That okay, go and start something there. I had a job in Manitoba Cancer Center, so I started the transplant center from first the private transplant center in Delhi. There was only one. My alma mater was doing in the government hospital. So then, from the taken journey, and I trained most of the transplant physicians who is working in Delhi and NCR. So I've been to Lagos almost 8-9 years when the Sickle cell found with me, and they have a meeting here. So this is my second visit to Lagos, and hopefully in the next 1 hour we will understand the basics of the transplant, because I still believe in the basics only, and then we can have an interactive discussion what we need to do much more better for our patients, so they should not land up in complication and they lose life after even getting transplant. So whenever while we're ready, we can start the things. So anything specific you want to listen, and I think more to discuss than So can I start, Professor? So actually, I work in the Max Healthcare, and BLK was the first Max Healthcare hospital when we started, and one of the prime hospital where it's almost like 600 bedded hospital plus, which deliver the quaternary care to all patients, including organ transplant, marrow, liver, kidney, the advanced cancer center, and the specialty center for each and every disease. Bone marrow transplant, when it comes, every transplant brings the notion that it's a surgical procedure. Marrow transplant, we all hematologists, oncologists, we do. It's not actually the surgery. It's a cellular therapy. It's a transplant done by physician, like those who are trained from the physician background, not surgical background. So I'm speaking next to So, a bone marrow transplant is the conventionally started long back in the late 60s by Dr. Donald Thomas, when after the Second World War, the people, those who had aplasia and how to rescue them started journey, that taken the donor stem cell from the posterior iliac crest, where the marrow is there, and infusing into recipient the peripheral blood system, and donor bone marrow cells start repopulating in the recipient marrow. So this is how the marrow transplant was started, and then it's basically to understand what are the basic objective of hematopoietic stem cell transplant. So bone marrow transplant is misnomer terminology nowadays days that what cell transplanted is stem cell. So everybody will be talking about the hematopoietic stem cell transplant. The primary objective is to deliver high dose lethal chemoradiotherapy to destroy tumor cell, to provide a source of hematopoietic stem cell, to salvage the ablated marrow, to stabilize the organ graft tolerance, to prevent rejection of the donor cells, to provide immune effector cells to mediate graft versus tumor activity. Next slide, comes. So, sorry for that technical glitch. So, marrow transplant. So, as I said, it's a donor stem cell collected from the posterior superior iliac spine, infused into peripheral blood of the recipient, allow the donor marrow cells to repopulate. That was how the journey begins in the transplant. And the primary objective of hematopoietic stem cell transplant is to deliver high dose lethal chemoradiotherapy to destroy tumor cells, to provide a source of hematopoietic stem cell transplant, to salvage the ablated marrow, to stabilize the organ graft tolerance, to prevent rejection of the donor cells, and to provide immune effector cells to mediate graft versus tumor activity. So when you look at these, the four ways you can cure or eradicate hematopoietic disease, cure hematopoietic malignancy, or defective hematopoietic cells. in case of sickle cell and thalassemia. So, and in the malignancy world, if you look at the objective, the immune effector cell, the graft versus tumor effect activity is primarily responsible for the better outcome and cure. So when as I said, the birth of marrow transplant after Second World War, because the research was focused on the lethal effect of radiation, and marrow was the most sensitive organ for radiation, and there were many deaths due to marrow failure. And that's how the transplant was started, and the first successful marrow transplant was done in late 1959, and the journey started since then. Got first successful non-twin transplant, and finally, who was the father of Donald Thomas from the Seattle, he got the Nobel Prize of the Medicine in 1990 for the beautiful discovery of the cellular therapy. So when it comes to the type of transplant as a physician, so it's all the terminology moves, and I think as a physician we need to aware of what it means. So sometimes we call marrow, bone marrow transplant when you collect marrow from the source. More recently nowadays there is every transplant is more than 90% is peripheral blood. So people collect stem cells from the peripheral blood. Umbilical cord blood is another source of the transplant that was famous before transplant came, where you won't get a full match related donor. And also depend on the donor type. So match related donor, when you have full match sibling donor transplant, or from the related donor, it can be haplo donor or unrelated donor transplant through the various international volunteer donor registries. A word about auto transplant, it's a misnomer term. It's basically high-dose therapy and stem cell rescue. There is no donor, so there is no transplant from the donor to the recipient. And all the advantages, as I said, in my first objective, high-dose chemotherapy. So in auto transplant, all the advantages is high-dose therapy. Advantage is lower transplant mortality. In that breast center, less than 1%. There is no rejection, no graft versus host disease, less infection, less immunosuppression, because there is no immunosuppressive agents are used. But the better disadvantage because it does give the lower cure rate. There is no graft versus tumor effect, and there is theoretically no possibility of potential tumor contamination when you do a stage 4 lymphoma and myeloma and sometimes neuroblastoma transplant. So auto transplant is basically collected, after the stem cell mobilization with the GCSF or chemotherapy, collect stem cells and preserve them, and after giving the myeloablative chemotherapy, these stem cells are re-infused. And you can treat and operationally get cure for many diseases, particularly multiple myeloma and non-Hodgkin lymphoma or Hodgkin disease. And if you look at the world, the registry, more than 60% of the CIBMT or the EBMT, the transplant is done for myeloma, because it is the most cheapest possible treatment and the best possible long-term survival. Still today's date, in the era of the newer drugs and cell therapy. So multiple myeloma, non-Hodgkin lymphoma, and Hodgkin lymphoma are the main indication in adult. Amyloidosis, sometimes germ cell tumor, and pediatric solid tumor like neuroblastoma hives. They are the disease mainly treated with auto transplant. Now, allo transplant, in contrary to its need allogeneic donor, which earlier used to say full match, now we call suitably actually identical. It has a graft versus tumor effect, and that's how the immunologically mechanism is cure, where donor immune response against malignant cell. So graft versus tumor effect or graft versus lymphoma or leukemia effect. It does have higher mortality because of graft versus host disease, infection, and with the better, currently with the prophylactic antibiotics, good antifungal and good immunosuppressive treatment, the rate of infection and disease is going down. So we could be able to control the higher mortality. And in the current era, when we do high immunosuppressive therapy, graft rejection is less, practically less than 1%. And what we see commonly today is that graft rejection is mainly for haplotransplant and they have antibody. So requirement for transplant, when you look at allotransplant, each transplant center has different requirement. But when you look at
the sibling donor transplant, at least you should have 3 allele match at A, B, B, or B1. And when you do haplotransplant, typically you are looking for 10 antigen or 12 antigen matching. So A, B, C, DRB1, DQ, and DP1. So you have to do the high resolution assay typing on the 4-digit level. And when you have a family, the sibling, you have 25% chance of the full match in each family. Larger family will have a better chance to find a full match donor. So in the 2005 before, it was like full match, whether related or unrelated, and then the journey of haplotransplant started in 2008. The T-cell repeat haplodonor transplant using simple drugs, post-transplant cyclophosphamide, and emerging standard of care option for patients who lack an HLA identical sibling donor. So if you look at that haplotransplant had changed all the registry, outcome is almost similar. Though the journey to transplant is different, cost, complications can be different, but outcome is same. And if you look at this 2012 onward, the haplo has taken over the even the next sibling transplant. And in today's world, every possible person who needs hematopoietic stem cell transplant for incurable hematopoietic disorder, they have chance to cure because everyone will have haplo identical donor, either for parents, mother, children, siblings. So you have a chance to get cure. And number of haplotransplants is they're increasing every year. And if you look at the trend from 2010, so haplo has taken over. Many diseases, the AML, and it's been that for every possible disease, whether malignant or non-malignant. So when you again move to the transplant type, so in the allotransplant, sometimes we call about myeloablative, and we give fully intensive the myeloablative chemotherapy, or people those who are less fit, so non-myeloablative transplant or mini allotransplant can be done. So it's not like the transplant a curative treatment only for fit patients. Sometimes it can be done for less fit patients also. And there is another terminology, immune intensity conditioning transplant, where you have the conditioning intensity anywhere between myeloablative to non-myeloablative. So you can do transplant from the age of 4 months. We have done the youngest transplant for skin, but the oldest is 80 years. So, and every person, I believe, on the earth, they have right to live, so they have right to get a cure and curative treatment. So, allotransplant, typically you need a donor, you collect stem cell, and then infuse after the conditioning therapy. And if you look at these the diseases, particularly in the whole world, if you look at the leukemia comes number 1, then the renal disorder, AML and ALL, and the MDS. CML earlier, there was not many transplants to be done, but after TKI, nobody does CML transplant, only for those who TKI failure or mutant, as the T7I2 mutant, or sometimes people who couldn't tolerate the TKI. But myelofibrosis, some high-risk lymphoma, and high-risk young myeloma, so they can be cured with the allotransplant. But in our part, Southeast Asia, Africa, if you look at, there are many non-malignant diseases which need transplant as a cure, particularly thalassemia, aplastic anemia, and sickle cell disease, and in the pediatric setting, the England representative, particularly PID and Fanconi. So allotransplant, what is required? You have to collect stem cell harvest. Whether when we do narrow harvest, it's at least done under GA, and in the cases of ABO mismatch, you have to do manipulate. Peripheral stem cell transplant, which is probably 90% plus the transplant is done today, is using GCSF or Paracetamol as a mobilizing agent, and you can collect every person on the earth. Allotransplant, we usually typically don't preserve the stem cell. In autotransplant, we do try to preserve. So in the PMT phase, there are typically 3 phases. You have pre-PMT, where is conditioning, the infusion, and the post-PMT phases. And every patient will go through the both donor and recipient the pre-transplant, the set criteria that who can donate or who can receive, the organ system function you have to do, and then only you can decide what kind of conditioning therapy you can actually plan. So these are the steps of the transplant. Every patient gets treatment with a transition because the transplant is a long journey, almost like a 1 month of the hospital stay. You have a secure venous access where you can deliver hydrochemotherapy, you take a lot of blood sampling, or you can stand into this culture with the whiteboard. The human prescribed to protect preserved cells will require the larger board infusion. So conditioning regime, every patient will get graft versus host disease prophylaxis, then they get stem cell infusion, wait for engraftment, and this patient will be monitored closely for almost 3 months, but lifelong actually. And long-term follow-up is required to look at the secondary complication of the transplant. And as I said, conditioning is primarily the treatment because you have to destroy the recipient marrow. So it can be non-myeloablative to myeloablative. So toxicity increases as your conditioning intensity increases. Young fit patient, the aggressive leukemia, thalassemia, sickle cell disease, most of these patients get the myeloablative conditioning therapy. And when you reduce the conditioning therapy, you are actually relying more on the graft versus tumor effect or immunological benefit. So a graft versus host disease prophylaxis, every patient will start before transplant or in haplocentric setting, the post-transplant setting, and it's a backbone for the allo stem cell, because otherwise the T cell of the recipient will kick off the donor's graft. So typically cyclosporine, methotrexate was the primary conditioning therapy since 1980s, and now these days you can have a tacrolimus, sirolimus, MMF, but again in the majority of centers in the world, still cyclosporine and methotrexate hold the place, and these have a very narrow therapeutic range, so you have to have all the CNI in the fixed limit of the, you have to do therapeutic monitoring. ATG is another drug which does prevent the graft versus host disease, particularly chronic graft versus host disease. So primarily the challenge after graft versus host disease is infection in transplant, and it does start with the ablation. So in the neutropenic phase, the typically gram-negative bacteria, the aspergillosis and HSV infection. But once you engraft, the primary culprit becomes, for majority of the transplant is CMV and other virus. And these patients will be like either splenectomized, immunodeficiency and immune reconstitution happen after 1 year. So in the next 9 months, they will be like prone for any patient who is splenectomized, encapsulated bacteria, the PCP, fungus, CMV. So these patients will require regular monitoring and surveillance. So the chronology of infection, as I said, in the first pre-engraftment, mainly gram-negative bacilli and aspergillus. Post-engraftments, the aspergillus and CMV comes, and the encapsulated bacteria. And there are multiple factors which affect the risk of infection, depending on the type of transplant, the timing of the transplant, pre-transplant factor, whether the patient is having graft versus host disease, mismatched transplant, graft type, and the immunosuppression used in the transplant setting, and conditioning regime. A word about graft versus host disease: it can be acute and chronic. Acute when you have typically within the first 100 days, and the incidence is around 30 to 40% in HLA identical sampling. Haploidentical transplant, it can go up, and main organ affected in the allo transplant is skin, gut, and liver. So there will be the rash, diffuse diarrhea or jaundice, and chronic graft versus host disease typically comes after the 100 days, and it's the resemble autoimmune disease like the lichen planus or scleroderma, and can manifest in the form of the mucositis, so the stricture, wound, liver disease, the dry eye, dry mouth, and so on. So, and every patient, has to be properly managed in acute graft versus host disease, because this is a major cause of the mortality, and you don't treat a very early GVHD, because there's more immunosuppression will lead to more infection, so you have to monitor them very carefully. And GVHD happens because there are immunologically competent donors cells in graft, the histocompetitive between the donor and host, and immunologically incompetent cell. So if you look at, you know, the benefit of the GVHDs, they were a problematic because in leukemia patient, those patients like twin transplant, there's zero GVHD, they have almost like 80% chances of relapse. So as I said, my fourth objective, immunologically benefit of the transplant. So if you have a graft versus tumor effect or graft versus leukemia effect, those who have an acute and chronic GVHD, probably they never relapse. The relapse rate is less than 12%. So GVHD is not cure. In the all hematologists are aware about the word DLI, donor lymphocyte infusion. In high risk malignancy, when you don't develop graft versus host disease by day 60, you actually sometimes preemptively use DLI, donor lymphocyte infusion, to have a graft versus host disease because you want to have some sort of immunologically activity. So patient those who have been transplant, B-cell deplete, transplant no graft versus host disease, they will be at high risk of relapse. So you have to manage the balance between the relapse and risk of the GVHD. Another complication typically you see in transplant, we know oncology disease, and that is typically manifest as painful hepatomegaly, jaundice, and ascites, or the unexplained weight gain. So this is more commonly seen with the myeloablative transplant like sickle and thalassemia, those who have either pre-existing liver disease, iron overload in thalassemia cases. So we have to be aware about this terminology, and now these days, because of new drugs like gemtuzumab, ozogamicin, or inotuzumab, those patients in the ALL or AML, those who receive this myelotab and inonja pre-transplant, they have very high risk of developing BOD, and people can die actually BOD because there is no treatment other than defibrotide, which can work, but it's very expensive medicine. Another complication of the transplant in the acute setting is hemorrhagic cystitis, and the typically seen because of either cyclophosphamide or late GVHD because of infection, particularly adeno or BK virus. So the chances of hemorrhagic cystitis is going high when you use high-dose TBI or this hydrocyclophosphamide, particularly in transplant setting. Post-transplant monitoring will be closely monitored for 4 years, and for more closer at first 100 days. Issue has to be looked at graft versus disease, infection, blood toxicity, engraftment, and survival. So today's date, the world has moved not immediate when you're discharging the patient. The immediate TRM comes at day 100. So if your day 100 outcome is met, a long-term complication of any transplant has to be looked at, particularly infection risk, and those who are with the chronic GVHD, those are getting immunosuppression for long term. So there will be the immunodeficient. The risk of infertility in the transplant is higher with the women than men, and those patients who have got the TBI or L-carnitine agents with hydrocyclophosphamide, they will be at high risk of the infertility, and we always allow the patient, those who are eligible, to preserve their semen or ovum before transplant because we have to put them back to normal society, and the family is the main. Hypothyroidism, when you use TBI, cataract, long-term steroid use, AVNDC, whenever the patient getting the long-term steroid for chronic graft-versus-host disease. Autoimmune dysfunction are very common, particularly in the chronic GVHD, and we have to look at the various other issues like dental and secondary malignancy post-transplant. Particularly, it comes with the PTLD, which are more seen in solid tumor, the post-transplant lymphoproliferative disorder, but you see in the hematological patients also. So immune reconstitution happens usually after 1 year, and those patients who get the treatment for chronic GVHD or steroid, their immune reconstitution get delayed. And haplotransplant also, immune reconstitution get delayed. And once the immune reconstitution happens after end of 1 year of immunosuppression, every patient has to receive the post-transplant vaccination because the immune system will be naive like child. So every patient should be given the post-transplant vaccination, and the live vaccine should be deferred till 2 years post-transplant. And here I just want to emphasize, and we all are aware that the live vaccine given for any immunocompromised patient, even oral polio to other sibling, other family member, they spread the virus, they excrete the urine, stool, and the people can get a paralytic polio or infection. So, and just switch to the major diseases, where allotransplant can be actually the path taking can be curative. So we all know relapse AML survival is around 5% to 10%. So if you do transplant early, and that's how the all the risk stratification, the cytogenetic or molecular, the favorable, intermediate, or poor risk comes. Those patients who have a AML CR1 transplant, who should be upfront transplant, where you have a sibling donor, poor intermediate cytogenetic risk, except NPM of like the unmutated. So every patient, and please compromise only 15% of the patient who are good risk. Otherwise, AML, if they are eligible, they should be upfront transplant, because if they relapse, as I said, outcome will be less than 5%. So 85% of adult AML and pediatric AML are indicated for allotransplant. Unrelated donor primarily look for poor risk cytogenetics, and if you look at the survival, whether 18 or the below 18 or after 18, the survival curve is pretty fantastic. You can do CR1 transplant, totally 60% of patients can survive. And the outcome, whether you have matched related donor, unrelated donor, or even haplo-transplant, will be the similar. Pediatric patients have better outcome because they almost get 70 to 80% long-term cure. So in ALL, if you look at the comes in the mind for individuals, only pH positive ALL should be transplanted, because we have notion that pediatric ALL is good disease, but adult ALL is worse than the adult AML. If you look at the data, the long-term survival is not. They do not tolerate intensive treatment like pediatric protocol, aspirin, steroid. They have diabetes. So it's even completing chemotherapy is more difficult in ALL patient, and that's how the ASTCT and the EBMT, where they suggest the patient, those who are highest patients, like pH positive ALL in first CR, primary refractory ALL in second or subsequent CR, or patients who are older than 12 years and younger than 56 years in CR1, if you have any adverse risk factor, whether hyperleukocytosis or any cytogenetic or molecular abnormality, they should be offered transplant, because outcome, those who have, you can see almost 70 to 80%, you can have an overall survival and event-free survival, better survival in the pH positive ALL. And again, this is the same like AML. If you do transplant in the first remission, you can 50% of patients still can get cured, and beyond the first remission, the survival and long-term outcome will be below 20%. So one should select the patient rightly for both ALL and AML, and the outcome are always better when you do after transplant. The pediatric transplant, those who are done in the CR1 for the highest patient. Otherwise, almost like 90% of patients do not require transplant in the pediatric setting. But CR1 or CR2, if you do to the right patient and right donor, outcome will be similar. And again, the donor type, I just want to say, the notion has to be clear that matched, related, unrelated, or haplo-transplant, they have outcome is similar. CML, as I said, we don't do transplant. Only and only we do transplant to patients who have not in chronic phase, advanced phase CML after releasing TKI with G315 I mutation, and second line therapy after imatinib failure, and third line therapy after second line TKI failure. Many times family of the pediatric CML, because they have also take lifelong immunosuppression, TKI, and then choose transplant versus non-transplant is a discussion with the family. And we sometimes do recommend one time, if they have a sibling donor, the CML pediatric patient should get transplant. The outcome is pretty good, and predicted the long back data because now there's you don't do CML transplant. Word on auto transplant for Hodgkin. Hodgkin is one of the curable malignancy. No Hodgkin should die. If you have good Hodgkin, ABV or now Nivo ABV or whatever the drugs, 70 to 80%. Once you relapse and relapse Hodgkin, if you do those who are chemosensitive relapse, again 80% of the relapse patient. So up to 30-80% again you get cured with the auto transplant. And even those who relapse after auto transplant, again for that 60% of patients you can cure. So if you look at 100 from the beginning, the more than 95% of Hodgkin you actually cure these days with the good the chemo or immunotherapy and the stem cell transplant wherever the applicable. Multiple myeloma, it is said the most cheapest drug today is possibly as a consultation is auto transplant. That's how why worldwide people are doing transplant. Because Dharma, now Germany, now CAR cell therapy, no, wherever alternative to transplant, they are hugely expensive and the biggest financial burden for patients. The non-malignant disease, thalassemia is one of the beautiful diseases to transplant because if you do in class 1 and class 2 early transplant, you can cure more than 90% of the patient. And the class 3 also, the leukaryosis, if you modify the conditioning, and nowadays I think we were the first to start after the treatment. So the Italian center, this thyroid Choudhary and outcome in class 3 also the very pretty similar to the class 1 and class 2. Aplastic anemia is like medical emergency. The MI you get stent primary angioplasty, you can rescue the heart. Aplastic anemia diagnosed today, tomorrow you should do transplant before multiple transfusion. The infection or bleed happens, and you can cure more than 90% of the patient, and they can be save a lot of money and morbidity and mortality. So aplastic should be treated as medical emergency as MI. And if you look at the post-pediatric and adult, whether you do any kind of the transplant, whether related, unrelated, APRO or mud, the outcome is pretty good. So aplastic should be treated because whatever the currently in the era, the infection is a killer. So whenever we are using ATG and wait for 3 months, they will succumb to infection or infection or bleed. So allotransplant for sickle cell disease in this part of the world is very prevalent, and you can actually cure more than 90% of patients if you do transplant at the appropriate time before the morbidity happens. PID again around 80% of patients, those who get the skin, was or other diseases, we can actually cure. So transplant actually cure many diseases. All the incurable hematologic disorders can be cured with transplant. So this is a thing that I realized in early this year, we have done around 1400 transplant, around 1000 allotransplant and 400 auto transplant because our part of the world, thalassemia, aplastic anemia, they are very common and they are always overburdened with leukemia and thalassemia. So since the 2015 haplo transplant is taken, we have almost like now these are almost 40 to 50% of haplo transplant because maximum will be 45%. So and this is the numbers what we do, and probably every possible disease we have had a publication in the international journal, so you can look at in the format. So outcome for thalassemia, haplo transplant in thalassemia, sickle, aplastic. So name any disease, any publication. So we have peer-reviewed our outcome data. So I'll end here and possibly take question from the audience. Thank you so much. Professor, we would like to know challenges you face in the respect to the managing hematopoietic disorder, particularly, here it will be only Sickle for everybody, but I think there are many more urgent patients who are leukemia and myeloma. So, your comments, sir.
Yeah, good evening, and thank you for a very wonderful presentation. My name is Wali Banduko. I'm a clinical hematologist at last week. I just have a couple of questions. One of them is, I want to know your experience with Campa. Have you used it before to prevent graft-versus-host disease? And what do you think about using it? Second one is that I noticed that in your presentation of graft-versus-host disease, both for acute and chronic, you somehow omitted the skin manifestations. And I know that it's pretty common and very worrisome for the patient. So I'm just wondering whether it was an oversight or you don't see it much in your kind of management. The third question is more of, I want to ask your opinion. And that is, if you met somebody who wanted to start doing a transplant in a resource-poor country, where would you advise him to start from in terms of which transplant would you do first? Would you try to do an allo transplant, knowing that you don't need the preservative? Or would you tell him to invest, despite it's a resource-poor country, in those -90 freezers and all that to preserve your, what's that? Yes. So would you want him to do that, or do you want him to try and do allo? Because with the allo, all you have to do is get it out of the patient and transplant it the next day. But also you have to preserve it for long, and then once the patient has been myeloablated, you can now give it again. So those are the questions I have. Thank you.
Okay. Thank you, sir. So I'll start from one by one. So Campeth, when I was fellow in Canada, that time we used to use, but I have not used Campeth. When back in India, it's hugely expensive medicine, and to control graft-versus-host disease, the majority of centers in the world are more to the ATZ. So rapid ATZ pre-transplant reduces the risk of chronic graft-versus-host disease. So Campeth still in the UK, because it's a Cambridge product. So they use a plastic. I think the majority of people don't use, and none of the problem with the CMV injection and all that, but because of the cost. So it does reduce the GVHD in the plastic. Second question, skin GVHD is a problem. Wherever you start, more than 25% area, you start first line treatment, which is prednisone milligram per kilogram, or wherever you have a stage higher, because it's where you have skin and gut, and so without doubt, without prednisone 2 milligram per kilogram a day. And because once you have an acute GVHD, progressive in 72 hours, it's very difficult to control that storm. So, third question was
how would you advise somebody in a
I will, that is my, I will do that. So, any other, so I will start. So, my view will be probably you can take it contrary to transatlantic or European. Those who are developed world, they can talk about anything, you have to have that minimum benchmark, maximum benchmark. But how we started in India is also, was developing country, still developing country, majority don't. So what is required for transplant. And the primary thing is that a committed a physician who is trained and who can be leader and he knows what he is doing. Nothing else is required. Nothing else is required. If he is there, then he can train 4 nurses and you can run your transplant center. And how I started, I was the first person, didn't have any support. I used to come to check my own protocol with my colleagues in Canada. So I believe to start with the allo transplant. Allo transplant or myeloma is nowadays is, you can do without transplantation. So allo transplant and myeloma transplant. One should not touch lymphoma and this cryopreservation, and there's so many problems comes. So myeloma, we don't preserve at all. You collect stem cell because it's, when you start program, it will be you are responsible. You tell the transfer medicine, just collect stem cell. This is kit. I need